Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoy today's podcast.
Welcome. I'm Jennifer Gilmore, a clinical research manager and registered nurse at the University of Toledo. Today, we'll be talking about shifts in cardiovascular medicine, specifically in improving how we assess cardiovascular risk. For years, low-density lipoprotein cholesterol, also known as LDL-C, has been the primary focus in risk prediction and treatment. But we're learning that LDL-C alone doesn't tell the full story. Emerging biomarkers like apolipoprotein B and lipoprotein a are helping us capture a more complete picture of a patient's cardiovascular profile. These insights are changing the way clinicians think about risk stratification and personalized treatment decisions, moving us closer to truly precision-based cardiovascular prevention. Joining me today to discuss this topic is Dr. Marilee Clemons, a clinical pharmacist from the University of Toledo who's passionate about lipid management and cardiovascular risk reduction. We'll talk about what these biomarkers mean in practice, when they can make a difference, and how this might change the way we approach therapy moving forward. Thank you for joining us, Marilee.
Thank you. I'm looking forward to our discussion.
Let's start with the significance of lipid biomarkers. What can they tell us about a person's cardiovascular or CV risk?
There's a growing recognition that LDL cholesterol alone doesn't tell the whole story of a person's cardiovascular risk. Novel biomarkers such as apolipoprotein B or ApoB, lipoprotein a or Lp(a), and non-HDL cholesterol, and some others like inflammatory markers, provide a more nuanced assessment. I'm happy to share what we know about the relevance for clinicians in tailoring risk stratification and treatment decisions.
To kick off our discussion, why is there a need to look beyond the traditional lipid panel?
So traditionally, when we think about lipids, we think about the standard lipid panel, which includes LDL-C, high-density lipoprotein cholesterol, or HDL-C, triglycerides, and total cholesterol. While these measures are valuable and have been used for decades, we now understand that in certain patients, these measures don't always tell the full story of a patient's cardiovascular risk. LDL cholesterol, for example, tells us how much cholesterol is being carried within LDL particles, but that value we receive on the lipid panel doesn't tell us the actual number of LDL particles. And it's the particles themselves that penetrate the arterial wall and drive atherosclerosis. So 2 patients could have the same LDL-C, but may have different levels of risk.
Oh, very interesting.
We also know that HDL cholesterol is not as protective as we once thought. Higher HDL doesn't necessarily translate to lower risk, and interventions aimed at raising HDL haven't improved outcomes. So relying on HDL-C as a marker of protection is really no longer supported by evidence. So this is where the concept of residual risk can come in. This is where patients experience cardiovascular events despite LDL-C values at target. In these patients, additional biomarkers such as ApoB, Lp(a), and non-HDL cholesterol, which are additional drivers of risk, may help provide a more complete picture of the patient's atherogenic burden.
Can you walk us through these major biomarkers, ApoB, Lp(a), and non-HDL cholesterol, and their roles?
For sure. So let's start with ApoB. This can be looked at as the count of all atherogenic particles in the bloodstream, which includes LDL-C, VLDL-C, which is very low-density lipoprotein, IDL-C, which is intermediate density lipoprotein, and even Lp(a). Each of these particles contain one ApoB molecule, so measuring ApoB gives us an estimate of particle number. This can be helpful in patients with diabetes or elevated triglycerides, which are situations where LDL-C may appear normal despite potentially having a high number of atherogenic particles. Some large studies and meta-analyses have shown that ApoB may correlate better with cardiovascular risk in these populations, but it's important to note that ApoB targets are not universally adopted in U.S. guidelines. The National Lipid Association released guidance on ApoB treatment targets. For borderline to intermediate risk, ApoB should be less than 90 milligrams per deciliter. For high-risk patients, ApoB should be less than 70 milligrams per deciliter. For very high risk, including history of multiple major atherosclerotic cardiovascular disease or ASCVD events, or one major ASCVD event and multiple high-risk conditions, ApoB should be less than 60 milligrams per deciliter.
That's interesting. So now that we've talked about ApoB, let's transition to Lp(a). For the listeners' information, Lp(a) is written uppercase L, lowercase p, with a lowercase a in parentheses.
Thank you for that clarification. So Lp(a), which is genetically determined, acts as an independent risk factor for ASCVD. What makes it concerning is that it's both pro-atherogenic and pro-thrombotic. The Lp(a) structure has an ApoB molecule attached to it, just like LDL-C does, but it also has an attached apolipoprotein A component that promotes inflammation and thrombosis. Elevated Lp(a) can be looked at as an independent risk factor for ASCVD. There are no treatment targets currently for Lp(a), but the National Lipid Association does classify patients as low risk when the Lp(a) is less than 75 nanomoles per liter or 30 milligrams per deciliter, and high risk as those with an Lp(a) greater than 125 nanomoles per liter or 50 milligrams per deciliter. I do want to note that depending on the lab, it can be measured in different units.
Okay, so we've heard about those two, but what about non-HDL-C? Our listeners may know about non-HDL-C from the recent Cardio podcast on practical approaches to lipid management, which we can link to in the show notes. The provider can calculate it on their own, or it sounds like some labs will report non-HDL-C specifically. The targets are easy to remember. The non-HDL-C threshold is 30 points higher than the LDL-C threshold for that patient.
Yep, that's exactly right. And you're right that the non-HDL-C isn't a separate lab order. It's the name for the remaining atherogenic cholesterols on the lipid panel, putting together LDL-C, VLDL-C, remnants, and IDL-C. Lastly, I would like to mention that there are some additional emerging biomarkers, things like remnant cholesterol and inflammatory markers such as hsCRP and GLIC-A. These are still fairly early in terms of clinical utility, but are helping researchers better understand residual inflammatory and metabolic risk. Regardless, the biomarkers such as ApoB and Lp(a) and non-HDL-C may give us a more comprehensive picture of a patient's true atherogenic burden beyond what a traditional lipid panel would capture.
How could ApoB, Lp(a), and non-HDL-C guide risk stratification and decision-making in practice?
Well, there's a couple situations where we could use these biomarkers. Specifically, they're helpful when we are trying to understand patients with residual risk, like we talked about earlier, or risk factors that don't quite fit the picture. For example, ApoB and non-HDL cholesterol are especially helpful in patients with diabetes, metabolic syndrome, or high triglycerides. In these settings, the LDL-C cannot be calculated or may even appear falsely normal because the calculation, such as the Friedewald equation, breaks down. This formula used to calculate LDL-C relies on the triglycerides being less than 400 for accuracy. This is where ApoB can give us some clarity because if ApoB is elevated, that patient still has significant atherogenic burden and likely needs more intensive therapy. With Lp(a), the focus is a little different. Lp(a) becomes important in the case of premature ASCVD, strong family history, or in that situation where patients continue to have events despite their LDL-C being at target. In those situations, measuring Lp(a) can help identify a genetically mediated risk that wouldn't otherwise be identified. But here's an important shift in how clinicians can consider thinking about cardiovascular risk assessment. Rather than viewing ApoB or Lp(a) as labs to order after a cardiovascular event has occurred, there's growing interest in considering their use earlier in patients as part of a more comprehensive risk discussion. Historically, these biomarkers were measured after someone experienced an event despite being on guideline-directed therapy. With newer evidence, some clinicians are exploring whether obtaining these markers alongside a lipid panel may offer context in situations where risk appears to not align with the traditional lipid values. Another consideration is that these biomarkers can simply help inform conversations rather than to prescribe or adjust medications. For example, if a patient's LDL-C appears to be at target, but ApoB is elevated, or Lp(a) identifies a patient as having higher genetic risk, this information can support shared decision-making with the patient. It can help foster conversation to discuss cardiovascular risk more concretely and really reinforce the importance of foundational preventative strategies, such as those outlined in the American Heart Association's Life Essential 8, which includes adequate sleep, physical activity, stress management, and other lifestyle factors.
I can see how, if patients have this information, they may become more engaged in healthy behaviors. These additional lipid biomarkers can help them better understand their personal cardiovascular risk, even when the traditional lipid values appear reassuring. All of this together represents an opportunity for a gradual shift from a purely reactive approach towards a more proactive and individualized approach focused on long-term prevention efforts. However, I'm not seeing many of my colleagues doing this yet, and I suspect it may be because the major groups aren't pushing for it yet.
The guidelines are moving in this direction, but they're not quite there. The American College of Cardiology / American Heart Association, National Lipid Association, and the European Society of Cardiology now acknowledge the role of ApoB, non-HDL-C, and Lp(a) as tools in refining risk upfront, especially for high-risk or borderline risk individuals. Where guidelines tend to be more cautious is in requiring evidence that shows the routine measurement of a biomarker leading to changes in management that clearly improve clinical outcomes. For example, we have decades of randomized trial data showing that utilizing medications to reduce LDL-C reduces cardiovascular mortality and morbidity. However, we don't yet have that same data for the biomarkers like ApoB and Lp(a). But we do know that these molecules are atherogenic, so they can help us paint a fuller picture of our patient's cardiovascular risk. Additionally, guidelines generally consider things like access, cost, and interpretation. If a test isn't universally available, covered, or actionable in a standardized way, they're careful about recommending it broadly. As a result, most guidelines currently list these biomarkers as risk-enhancing tools rather than required testing.
Great. Can you touch on indications for testing, specifically looking at primary versus secondary prevention?
So going along with what I just mentioned, the national guidelines have not yet provided clear and aligned recommendations on when these should be ordered, particularly in primary versus secondary prevention. In secondary prevention, we already know that aggressive lipid lowering is indicated regardless of the biomarker testing. In those cases, biomarkers may add nuance in the use of therapy, but they generally don't change the overall treatment decision. In primary prevention, things are less clear. What I can say is that they can be used when traditional risk calculators don't fully explain a patient's risk or when there's a strong family history or concern of inherited risk. I do want to note that the National Lipid Association does recommend measuring Lp(a) at least once in a patient's lifetime to help identify genetically mediated cardiovascular risk. That reflects a growing consensus that Lp(a) can identify risks that wouldn't otherwise be detected with a standard lipid panel. For ApoB and non-HDL cholesterol, expert societies acknowledge their usefulness in refining risk, but again, their use is positioned as optional and individualized rather than routine.
Okay, so what about insurance coverage? Is that part of what limits broader adoption?
It certainly can play a big role. Non-HDL cholesterol is the most accessible because it doesn't require an additional test since it's calculated from the standard lipid panel. My experience is that ApoB and Lp(a) testing may be covered by insurers. However, it's certainly important to think about this impact on care and have transparent discussions with our patients. I would recommend that patients check with their specific insurance plan about coverage for these tests.
All right, moving on to treatment. What pharmacotherapies are available or emerging to target these biomarkers?
Okay, so when it comes to lowering ApoB, LDL-C, and non-HDL cholesterol, statins remain the foundation of therapy due to their robust outcomes data. High-intensity statins lower both LDL-C and ApoB and are first line for patients with ASCVD, diabetes, or elevated risk. Ezetimibe and bempedoic acid offer an additional 20% reduction in LDL-C and ApoB and are useful in patients who need additional lowering or who cannot tolerate statins. PCSK9 monoclonal antibodies, or mAbs, provide larger reductions, about 50 to 60% in LDL-C and about 40% in ApoB, and they've demonstrated cardiovascular risk reduction in primary and secondary prevention. They also offer about a 20% reduction in Lp(a), but it's unknown if that is clinically relevant. Inclisiran is a newer option that lowers LDL-C and ApoB through RNA-based inhibition of PCSK9 and may be helpful for patients who cannot tolerate other therapies, cannot self-administer medication, or prefer infrequent clinic-administered dosing. However, cardiovascular outcome trials are still ongoing. Inclisiran is generally processed through the medical benefit versus pharmacy benefit, so accessibility can actually be better from that perspective. I do want to note that there's no FDA-approved therapies specifically targeting Lp(a), though there are several therapies in late-stage clinical trials that are showing promise for the future.
Okay, lots of options there for sure. Thanks for that summary. And again, we'll link our podcast that goes through more details on these medications in the show notes. Now, considering the information you just discussed, can you walk us through how clinicians can decide which therapy to use for which patient?
When we think about choosing therapy, it's really centered on two things. The first is what is driving that patient's risk? And the second is what's the most effective and evidence-based way to lower that risk? As I mentioned before, we can use those markers in a preventative way or for those with residual risk. If the biggest issue is elevated ApoB or non-HDL cholesterol, then the first line is always a statin and ideally a high-intensity statin if the patient can tolerate it. From there, the next step is guided by how far away from target the patient is. If they need about a 20% reduction or less in these markers, then ezetimibe or bempedoic acid could be a good option. If they need a larger reduction, you'll need to go towards the PCSK9 mAbs. For an elevated Lp(a), the approach is different because we don't have a dedicated Lp(a) therapy. So we focus on aggressively lowering risk factors like LDL-C, non-HDL-C, and ApoB, possibly even blood pressure or weight loss to offset that inherited risk. From a lipid standpoint, this typically means combo therapy of a statin plus a PCSK9 mAb, possibly ezetimibe or bempedoic acid when appropriate. Inclisiran also plays an interesting role here. If we determine a patient needs a large reduction in LDL-C or ApoB, maybe 50% or more, but struggles with remembering to take medications, has difficulty with self-injection, or really just can't tolerate a PCSK9 mAb, inclisiran can be a good option because it's given twice a year, which can really simplify a treatment plan for a patient. For patients with statin intolerance, we'll look at the magnitude of reduction needed, but in this instance, bempedoic acid, PCSK9, mAbs may be a key tool given the cardiovascular outcome data.
That was really an insightful discussion, Marilee. Thank you for explaining why we need to look beyond the traditional lipid panel and understand the role of these emerging biomarkers in ASCVD risk assessment. If there's one message to take away today, it's that incorporating measures like ApoB, Lp(a), and non-HDL cholesterol gives us a much clearer picture of a patient's true atherogenic burden. They help identify risk earlier, personalize therapy, and make more informed decisions, especially in patients where the traditional lipid panel may underestimate risk.
Absolutely. It really is an exciting time in cardiovascular medicine and lipid pharmacotherapy. These biomarkers will help us move from a one-size-fits-all approach to a more personalized strategy for ASCVD prevention. And as newer therapies come to the market, especially those targeting Lp(a), our ability to provide highly effective, specific, and genetically targeted approaches to lower these risk factors will only improve.
Thank you again for your time, Marilee.
Thank you so much for having me. I've really enjoyed this discussion.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.